I would like to introduce Dr. Gabriella Hobbs. Dr. Hobbs is an associate professor and a clinical director of the Leukemia Service and the MPN service at the Massachusetts General Hospital and Harvard University. Dr. Hobbs will be talking to us today about women in MPNs, clearly a very important topic and with a lot of interest. I think there are even more people upstairs because the room filled up. So Dr. Hobbs, the floor is yours. Thank you for presenting on this topic.
Thank you so much. Thank you so much for inviting me to talk. I've never been to the patient symposium of this conference, so very excited to be here, and hopefully I'll keep you all entertained while you're having lunch. So I'm happy to talk about women and MPN, obviously a topic that is very near and dear to my heart. So I'll talk about a few different things that kind of span the woman's lifespan. So first we'll talk about fertility considerations. We'll talk a little bit about preconception, then what happens during pregnancy, and then I'll end by talking a little bit about menopause. So just a little bit to kind of ground everybody, although of course we've been talking about this all morning. So, but just to put it in perspective in the context of, women as they go through their journey. So the average age of diagnosis is in their 60s, but as we all know, a lot of patients get diagnosed earlier than that. So up to 20% of patients with MPNs are diagnosed younger than 40. And I certainly have patients that have been diagnosed in their 20s, and even some patients that I've inherited from pediatricians that were diagnosed when they were earlier than 10 years old. ET is more common, followed by PV, and then myelofibrosis is the rarest of the three MPNs. Women more commonly have ET compared to PV and myelofibrosis. And myelofibrosis is more common in men than in women. Of course, when talking about MPNs or in general, women are obviously better than men. I'm not biased at all. But biologically, this might be interesting as well, which is interesting. So there's been some studies showing that perhaps women have less mutations, like other mutations outside of like the three typical ones, meaning lower high risk mutations and maybe even lower JAK2 levels. Women may be younger at diagnosis. Is that because they're actually younger at diagnosis, or maybe they just seek care earlier? Sometimes women may have more indolent disease than men. But, and one thing that we'll talk a lot about is that women may be more symptomatic, or at least more willing to talk about their symptoms. Sounds familiar for many things in life, right? All right, so there was a study called the MOST study that I'm showing you on the slide here. And we're looking at gender differences in patients with myelofibrosis or essential thrombocythemia. The men are in the green and the women are in the reddish maroon. So as you can see, really women have significantly more symptoms or endorse more symptoms than men. Fatigue is all the way on top. We've talked a lot about fatigue today, heard a lot about fatigue, but it's not just that. Lots of different symptoms seem to impact women more than men. And this study here also demonstrated the same thing, looking at just kind of a composite of all of the symptoms or symptoms by themselves. Again, women seem to have more symptoms than men. And these can include things like fatigue that we spoke about. But in addition to that, women are more likely perhaps to struggle with abdominal symptoms or other symptoms that we think about with MPN. And then one thing that I thought was interesting as well is that women with an MPN are more likely than male counterparts to take medical disability. So these symptoms are not just like, oh, I'm a little bit tired or my stomach hurts, but really they can be significant and can really impact how women experience these diseases to the point that they have to take disability from work. So I think recognizing the symptoms and addressing them, obviously, as MPN doctors is really at the center of what we do. So a common question that I get from my patients is, can I have kids? Women that are diagnosed early. Does this affect my fertility? And so, when we're thinking of advising folks about pregnancy and fertility, we want to know, does this disease impact my ability to get pregnant? And then if I do get pregnant, will I be able to carry that baby to term? So MPN by itself, as far as we know, doesn't affect fertility directly. That being said, the treatments that we may utilize to treat an MPN, depending obviously on the stage of the MPN, can definitely have an impact on fertility, or they can at least impact how we think about when to get pregnant. In MPN generally, especially when we're thinking about ET and PV, the medications that are used don't generally impact fertility directly. Now, that doesn't mean that they are safe to take when you're trying to get pregnant, but the medications themselves don't have a direct impact on fertility. And again, another important point to remember is that most women that are thinking about getting pregnant generally have lower risk disease that doesn't require them to be on a lot of these medications. And so thankfully, we don't have to consider so many medications, but that's not always the case. We'll talk about that a little bit more. And so I think an important thing is to recognize that it's important to talk about these issues with your MPN doctor, because I've found when I try to pair my patients with a high-risk obstetrician that the OBs may not have a lot of experience with an MPN. And so being able to have a conversation with your MPN team and being able to tell them what you're looking for and what's important to you helps. And then the MPN doc can kind of communicate with the gynecologist or obstetrician and say, hey, here are the things that we worry about. So that, you know, the last thing you want is you're already worried enough about the MPN and pregnancy. You don't want to have a doctor that's not super familiar with these diseases making you more worried. So something to kind of keep in mind. All right, what about when patients are trying to conceive? Is it safe to take medications? So some of them are okay, and some of them definitely not. Aspirin, and we'll talk a lot about aspirin in the next couple of slides, is definitely safe to take and really recommended to take for basically women during pregnancy. And this is important because there's some young women that maybe aren't on aspirin as part of their MPN. And then interferon, we've heard a lot about interferon today. Interferon is safe during pregnancy. And that's an important consideration for women that need to be on interferon, although like I mentioned, many women actually do not need to be on any treatment during pregnancy. Now, the other medications that we all are familiar with for MPNs really probably need to be discontinued, and we need to have a conversation about how to handle that as we're trying to get pregnant. So hydroxyurea, negrolide, and JAK inhibitors, definitely less is known about their impact on fertility. So question is, you know, I'm on hydroxyurea, I'm on interferon, I'm on a JAK inhibitor. How long do I have to stop that for before I get pregnant? And there, unfortunately, there's just not a ton of data about when folks needs to stop those medications. So it's important to start having a conversation with your doctor so you can start planning. All right, pregnancy considerations. So this is not just true for an MPN, but true in general. Important to know what medications is safe to take before you become pregnant so you can plan, you know, do I need to switch one medication for another one? And when we're thinking about pregnancy, we're thinking about the risks to the mother as well as the risk to the unborn baby. I did say a negative thing about this before, but it is, I think, good to have a good relationship with a high-risk obstetrician, even if it's doctor-to-doctor communication. And hopefully in the same center where you have your doctor so that communication is a little bit more seamless. Doesn't always work, but I think it's important. So we are used to an MPN thinking about risk stratification. And, you know, when I meet a patient and we talk about, do you need to be on medication to lower your blood counts? We talk about, you know, is your disease at high risk for having blood clots? And if so, you need to be on a medication to lower your blood counts. And for pregnancy, we sort of think about it the same way with some different considerations. So if a person has not had a blood clot before, they do not have a history of abnormal bleeding, they have not been previously on medications to lower their blood counts, those patients should be considered low risk. Higher risk patients, similarly to when we're talking about MPNs in general, are patients that have had clots before and have needed to be on previous on medications to lower their blood counts before. And then another kind of like pregnancy specific consideration is, what do we think about patients that have had several pregnancy losses? Do we consider that kind of like a thrombotic event? And there's no clear guideline about that, but certainly if patients have had just one pregnancy loss, that's pretty common in the general population, but patients that have had multiple pregnancy issues, that's where I think it's a good time to have a conversation with the OB and say, would this be a patient that we consider higher risk for pregnancy? And then maybe because of that, think about having them on a cytoreductive therapy or a blood count lowering medication. So what treatments do we do during pregnancy? So if you're low risk, and this is where it's a little bit different than for patients that are not pregnant, everybody should be on aspirin. So, if we have patients outside of pregnancy that have a calreticulin mutation that are very young, that have not had a blood clot before, those patients actually are so low risk for blood clots that we don't recommend being on aspirin. But when it comes to pregnancy, everybody really should be on aspirin. Phlebotomy can be utilized to get our hematocrit less than 45, although really the baby is an excellent phlebotomist. And so usually most women do not need to be getting phlebotomy during pregnancy because they'll become iron deficient naturally during pregnancy. And then this part is kind of like a consensus guideline. So there's no like lots of studies that have been done to come up with this recommendation, but this is the recommendation that we've come up with to prevent blood clots at critical times during pregnancy. So the times where people that are at higher risk for blood clots is right before pregnancy ends, right before delivery, and the 6 weeks after delivery. So at that time period is where we really recommend, and in practice, it's really 6 weeks after delivery that we recommend being on a blood thinner. For patients that are high risk, same thing, but we also recommend being on a medication like interferon throughout the pregnancy, if necessary, to lower their blood counts. An interesting phenomenon that we see during pregnancy is that people's blood counts actually tend to normalize a lot. So people with ET can have really, really high platelets before pregnancy, and then as pregnancy goes on, platelets kind of tend to normalize, which is always really interesting. And then once the baby comes out, platelets go right back up. All right, so treatment during pregnancy. This definitely easier said than done, but this is the recommendation. And this is more applicable to patients that are going to have a planned delivery, like a C-section or a plan to be induced. If you can stop the aspirin a few days before the due date, stop anticoagulation a day or two before labor. And then patients can remain on medications like interferon, but really hydroxyurea is not a medication that patients can be on during pregnancy or during breastfeeding. Interferon is an interesting question. People have asked me, is it safe for me to be on interferon when I'm breastfeeding? And there's not a lot of data about that, but really the amount of interferon that would make it into the breast milk is really, really tiny. And then remember, interferon is a medication that is not orally absorbed. We inject that. So if the baby were to get any interferon in the breast milk, that would probably be digested. And so there's probably very, very low chance that the baby would get any interferon. But again, that's just, if you look at recommendations, probably says you can't do it, but I've, case by case, I think it's okay to consider it. So I did this work with a colleague of mine, Dr. Howe, and we reviewed our experience at Brigham and Women's Hospital, Dana-Farber, and Beth Israel, and Mass General to see, how do people do when they have an MPN and get pregnant? And so we reviewed 130 pregnancies. Most of them were in patients with ET because, again, most young women, if they have an MPN, are going to have an ET diagnosis. Not surprisingly, the vast majority of them, or more than half of them, had a JAK2 mutation. Median age of pregnancy was 34. The live birth rate was 70%, which is actually not that different than the general population. And there was some patients that had a spontaneous abortion before week 20 in about a quarter of the cases. And then a small percentage had issues with clotting and a larger percentage with bleeding, which is really not that different from the general population. So we learned there's an opportunity to improve outcomes, but it's possible also that patients in prior decades maybe were treated differently. And now we're a little bit more aware of this. And so we treat it hopefully better. So the live birth rate is similar to the general population. And what we found in this study is that patients that were on aspirin definitely had better outcomes than those that were not. And so, as I mentioned before, we always recommend being on aspirin if you have an MPN. Prior pregnancy losses we found increases your risk of having future pregnancy losses. And this is not unique to an MPN, but something specifically to think about in MPNs. All right, so beyond pregnancy, what about birth control? So again, not a lot of data. We kind of extrapolate from other diseases that have a higher likelihood of having blood clots. And so generally speaking, we do not recommend estrogen-containing birth control because of the increased risk of blood clots. So what are the options? We have progesterone-only contraceptives, and we also have intrauterine devices. So I personally, to my patients, if it's appropriate, recommend an IUD. And the nice thing about an IUD is that it also lowers really like menses in general. And so one issue that hasn't been studied enough, but we always talk about, do you have abnormal bleeding? a lot of young women that are menstruating and are on aspirin really end up having very heavy menses. And so the IUD can really kind of help with both of those issues. And as with anything, you may not think that you're going to see your hematologist and you need to talk about birth control or pregnancy, but I think it's important to bring it up and to talk about your concerns and to make sure that they're being addressed. So, all right, we're talking about pregnancy, we're talking about contraception, and then fertility. Well, what about libido? So this is also something that occasionally patients will bring it up, but many times they really don't. And so I think this is also an important time to kind of pause and talk about this as well. So living with a chronic disease can be associated with a lot of anxiety, sometimes depression, and uncertainty about the future. And all those things can really get in the way of libido. So, patients may be thinking, what is the future holding? I'm really symptomatic from my disease, I'm fatigued. Maybe you're on medication that has side effects, and that can get in the way of libido as well. If you have other symptoms like sweats or itching or headaches, et cetera, all those things, in addition to living with a chronic disease, can really get in the way of libido. So again, this may seem like an embarrassing topic or something that you don't necessarily want to talk to your hematologist about. But I think it's an important thing to bring up, because there's some things where certainly we can't do anything about guaranteeing that the future is going to be just fine. But I think bringing up the subject and helping to ensure that you have the information you need to feel less uncertainty about the future if possible, and then having those symptoms well controlled, I think really can go a long way. So which patients are the ones that are most likely to have sexuality issues? So myelofibrosis patients, because they tend to be older and more symptomatic, tend to have more issues with sexuality than younger patients. So MF patients certainly more impacted than PV patients, and PV patients more impacted than ET, probably because more PV patients have more symptoms than ET patients. And then patients that have low blood counts, especially that are on medications and need transfusions, are certainly more at risk for having issues with sexuality. And generally patients over the age of 60, but really anybody is at risk. So like I mentioned before, talk to your doctor about it, make sure that your symptoms are well controlled and that everything is being addressed that can be addressed. And then lastly, menopause. Gosh, this is a hard one. I know Dr. Mesa mentioned this briefly in the morning, but we are always talking about symptoms with MPN, and I wish we had like a test to know, are my symptoms related to the MPN or are my symptoms related to menopause? And sometimes it's really hard to know. And I think it's just important to name that and to recognize that there's uncertainty, that we don't have a magic test that can tell us your fatigue is due to this or your hot flashes are due to menopause and not due to your MPN. And it can be hard to know. And I think definitely important to make sure that you're addressing both, because the last thing that you want is to be put on a medication for your MPN when really all you need is treatment for menopause. And so again, a subject that you may not think that needs to be brought up to your hematologist, but is really important, is symptoms that you may be having because of menopause. And here, I'll say this, that we may require some trial and error. So if we address the menopause symptoms initially with some of the therapies that your gynecologist may recommend, and that's really not doing anything, you're still having lots of hot flashes. In MPN, we always talk about night sweats, but sometimes it's not night sweats. Sometimes patients really do have kind of like feel hot and it's during the day. And that may be related to the MPN and not to menopause. And so I think, having that conversation, keeping track of your symptoms can really help. And then one thing that I've changed recently in the way I think about treating these symptoms is hormone replacement therapies. For a long time, everybody was on hormone replacement therapy. And then we were like, no, nobody can be on hormone replacement therapy. It's bad and has all these complications. And then I think the field has moved again. And low dose hormone replacement therapy has definitely become much safer. And this is, again, an area where we need some investigation, but I have had a lot of patients that really were struggling with symptoms. And then just being on low dose hormone replacement has really helped with the symptoms. And so again, having a conversation with the MPN doc and saying like, can I be on hormone replacement therapy? What are the increased risks of being on hormonal therapy to my risk of having blood clots? And I think if you're optimally managed from an MPN perspective, you're on aspirin, you're on the medications you need to be to prevent blood clots and doing all the other great things that we were hearing about today to prevent inflammation and all of the other comorbidities that Dr. Hasselbeck talked about. And I think it's appropriate for some patients to be on low dose hormone replacement, and that can be really, really helpful to improve a lot of these super bothersome symptoms. So in summary, there are differences in how men and women experience their MPN. It's hard to know if that's biologically the way that it is, or it's just that women experience those symptoms and talk about those symptoms differently or seek care differently. But it does really have an impact in their life. It's important to discuss issues related to fertility, pregnancy, and menopause with your MPN doctor, and recognize really the limitations, right? There's no standard guidelines. So again, that's why I think having open communication is so important, so that we can do that trial and error, knowing, the limitations of our treatment. And then we may also need help from other specialists, like an OBGYN, to help us, find those optimal treatments. And lastly, I know I said this a few times, but don't be afraid to talk about these things with your doctor. Thank you so much.
Thank you, Dr. Hobbs. For questions, we do have the Q&A at 2:15, so keep those in mind, or on paper, better on paper. And you're free till 1:15, so I guess at 1:10 upstairs to begin our next session at 1:15.